Hi guys, my name's Eva and I'm going to be doing a teaching session on probably the most common general surgical presentation you'll encounter in F1, F2, and that is abdominal pain. So we're going to do this as kind of a case-based teaching session. So our case is a 32-year-old lady. She had 5 days of generalised abdominal pain and she's not really got past medical history or drug history to speak of. That's the information that you have from your handover and you're asked to go and see her. So initially, history of presenting complaint and pain. I always start with Socrates, so there's a bit of a reminder there on the right hand side. So her pain is all over, started randomly whilst watching television, so she wasn't doing anything. It feels like it's throbbing and there's no radiation of it. She feels nauseous and feverish with the pain, and it started 5 days ago and is getting progressively worse to the point of now it's about an 8 out of 10. There's no exacerbating or relieving factors. I do like to use quotes generally in my clerkings, and I think that's a really good way of depicting someone's pain. That's just a tip. With abdominal pain or abdominal symptoms, the way I find it easier to think of questions is based on organs. So I think about all the organs in the abdomen and what symptoms they can produce and do it that way systematically. So starting with the lower gut, lower GI, are bowels opening regularly? What's the consistency like, and is there any bleeding? So she's not got any symptoms from that point of view. Also talk or think about flatulence or lack of if you're worried about bowel obstruction. Upper GI, so any nausea, any vomiting, any dysphagia, so difficulty swallowing or painful swallowing, reflux symptoms. She's not got any of those, or she's got a bit of nausea, but none of the others mentioned. Urinary symptoms, always important to remember, especially in lower abdominal pain, but older people can present with generalised abdominal pain coming from their bladder. So asking about the last time they passed urine, are they in retention? And then asking about UTI symptoms, so dysuria, increased urinary frequency, and hematuria. The main take home from this that I want everyone to kind of take away is gynae pathology is the biggest differential in a young woman with abdominal pain. So always ask when their last period was, so could they be pregnant? And we'll come on to this in a little bit as well, but ask about their past medical history. Have they had any previous abdominal or gynae surgery that could be predisposing them to a torsion, or do they have a coil in that could maybe make it more likely they've got an ectopic pregnancy, etc. So we know her last period was a week ago, and that was with withdrawal bleed because she's on the combined oral contraceptive. Generic symptoms, so infection, fever, and then thinking about in older patients as well, always good to do a bit of a screen, any weight loss, any night sweats, thinking about cancer as the cause for their presentation. Forgot to say as well, in men you can sometimes get testicular pain that is referred into the abdomen, so it can present unusually, especially in older people. And never forget kind of a lower chest cause of upper abdominal pain, so a pneumonia, probably most commonly. Sometimes you can get lung cancers that present with upper abdominal pain as well. So this is her other past medical history, which we've already discussed. She's not got any family history, so no bowel cancer. You can ask about IBD as well. And social history-wise, she doesn't smoke. She does drink quite a bit. So smoking predisposes you to, I guess, cancers in general. And alcohol, increased alcohol intake, you'd be thinking about maybe liver disease. Although she's quite young, and that would make it less likely. So these are her OBS, and this is her A to E. So I would always start an examination, especially on kind of a general surgical take, with an A to E. It's okay. She's saturating fine and her chest is clear, so we're not worried about respiratory pathology. Coming on to C, circulation. So her heart rate is quite fast, although regular. At this point, given how fast her heart rate is, you'd probably want to intervene and do something and then kind of reassess. So that's the most important thing with A-to-E's, is when you find something that's wrong, you go back and fix it. So you could get an ECG to see what the rate is, to see what the rhythm is, sorry. So most likely be a sinus tachycardia in someone this young, but in someone older they could be in AF, or they could have just a more dangerous rhythm going on. So it's always important to know what the underlying rhythm is. But given this is probably a sinus tachy, she's probably got a bit of an infection going on. She's dehydrated, as you can see with the rest of C. It wouldn't be a bad idea to start with maybe a 500 ml bolus of fluid and then reassess her heart rate. Although she is holding her blood pressure, so you do have a little bit more wiggle room. But that would be something that I would probably act on before I moved on. In terms of D, nothing really to note. Always important to check BM and ketones, because you can get diabetic ketoacidosis presenting with abdominal pain and vomiting. And her abdomen, soft, although she has localised tenderness to her right iliac fossa and some voluntary guarding. It's always important to document whether that they're not peritonitic. If they are, then obviously document they are, but that's an important negative, because that if she was peritonitic, then that would make it more of a surgical emergency. It might be that she needs to be rushed to theatre a bit quicker than if she wasn't. You can also look for more kind of other signs, so in the hands, in the nails, in the eyes, but I'm not going to talk about that at the moment. So pregnancy test is the first investigation I would do, or urine test in general. We could do pregnancy and urine dip at the same time. That will rule out pregnancy as a differential, and it will also look at, I guess, renal pathology, so like renal stones normally gives you blood in your urine, and also obviously urine infection as well. VBG is one of the first kind of blood investigations I would do in an acutely unwell abdominal pain. A raised lactate, her lactate is quite raised, so you get that with an increase in anaerobic respiration, normally in a response to kind of sepsis, normally as a response to sepsis or severe infection. So this is an indicator that she is quite unwell, and to be honest, giving her that bag of fluids might be what she needs to bring that down. So I'd give her maybe a 500 bolus, and then maybe another hourly bag or something, and recheck the lactate just to make sure it's downtrending. She's got a neutrophilia and quite high CRP, and always important to check renal function, because you're most likely going to give her antibiotics, and some antibiotics are inappropriate with reduced EGFR. Thinking about imaging, what would we do next? So these are things to consider, not necessarily all in her case. So an erect chest x-ray, looking for pneumoperitoneum if you're suspecting bowel perforation or gas where it shouldn't be in the abdomen. I don't think that's relevant in her case. The main thing I would think about in her, so in a young person, ultrasound. So if she's got upper abdominal, right upper quadrant, pathology, then you could do an upper abdominal ultrasound, and that will look for things like gallstones and whether the gallbladder looks inflamed and kind of gunky. But in her case, generalized abdominal pain, right iliac fossa tenderness, I'd be doing a transvaginal ultrasound, which will not only look at her appendix if they can visualize it, but also look at her ovaries to look for torsion. And that would be the first imaging that I would do on her. CTs are debated in general surgery. Everyone has their own kind of cut-offs. I would leave that more to be a senior decision. In appendicitis, which is what we're suspecting in this case, CT is more sensitive and specific, but obviously in younger people it's not really appropriate, and sometimes these patients are treated clinically. CT angiogram can be useful in large PR bleeds or bleeding within the abdomen. So her transvaginal kind of gave it away. Ovaries unremarkable, and her appendix is edematous and in keeping with appendicitis. This is a good diagram to kind of pause and take in as differentials based on the area of pain, but I won't go through it now. And then I just want to quickly talk about a junior approach to a plan if you suspected appendicitis. So I would always keep the patient nil by mouth if you're not sure. If they need surgery, then it's the most important thing is that they don't eat. So sometimes I put nil by mouth until senior review. In a case like hers, if she's well with the appendicitis, it's likely she'll be operated on the next day, so she doesn't need to be nil by mouth. But until you kind of get a feel for that, it's important to keep them nil by mouth. I'd give her IV fluids, which we've already discussed, but also maintenance fluids if you're going to keep her nil by mouth. IV antibiotics, which in my trust I think is amoxicillin, metronidazole, and gentamicin, triple antibiotics to treat for suspected appendicitis, again taking into account EGFR. And then a senior review is always necessary to decide on the more surgical approach.